ECG interpretation of those ECG that were shared yesterday. First of all, you can see the P wave in the lead 2. So there's a sinus rhythm. Both lead V1 and lead AVF are upwards, so their axis is normal. And after that, we can calculate the rate by counting the QRS complexes between the two R waves, as the rhythm is sinus, and then we can divide the 300 with the number of boxes that are present between the two R waves. After counting the rate, we start looking at the PR interval, morphology of the P wave, PR interval, and then the QRS complexes, and also the ST segment. One thing is very obvious in this, that there is a small Q wave in the lead 2 and ST segment elevation. So when you see ST segment elevation in lead 2, so what are the other inferior leads? Lead 2, lead 3 and AVF. So you can find ST segment elevation in lead 2, in lead 3 and lead AVF along with the small Q waves. Another important thing you can note over here, in the strip leads, can you see that there is a PR interval that is prolonged over here, and then there is a PR interval that is more prolonged, and then here more prolonged and very much prolonged, then the drop of the here there is drop of the QRS complex. Alright, so this is Wenke-Beck phenomena. And another thing that you see is that there is ST segment depression in V5 and V6. So basically this is second degree atrioventricular block, yani कि Wenke-Beck block with acute inferior STEMI, and these are the reciprocal changes that you can find in the form of ST segment depression in lead V5 and V6. The second ECG, the thing is that you can find a P wave. So this is a sinus rhythm, and then both lead 1 and AVF, lead 1 is upwards and lead AVF is down. So this is left axis deviation. After this, you can see that PR intervals are normal. You can calculate the rate as well by dividing 300 by the number of boxes that is present between the two RR waves. But the important thing over here is that the QRS complexes are very broad. So these are broad complex QRS complexes. Along with that, when you look at the QRS complexes, every lead, you can see an M pattern in the lead V6. So when you find an M pattern in the lead V6, and also there are inverted T waves that are present in lead 1 over here, lead AVL and lead V6. So whenever you find the M pattern in the lead V6, this is the along with left axis deviation, this is left bundle branch block. So whenever you find left bundle branch block in ECG, the further interpretation of the ECG is not possible. So this is simply sinus rhythm with left bundle branch block. In this ECG, again, you can find a P wave in the lead 2, so the rhythm is sinus. Lead 1 and AVF both are upward, so the axis is normal. Then you start looking at the P wave morphology. You can calculate the rate as well by the method that I have told you. Then afterwards, you start looking at the PR interval and the QRS complexes, but you can find a T wave inversion in lead V1. So when you are finding in the lead 1, which is a lateral lead, you will see that you will find T wave inversions on all the lateral leads. Look, lead V1, AVL, V5 and V6, these are the lateral leads. So you are finding this is following a vascular pattern. But if you see at the T wave inversion, this is again asymmetrical T wave inversion. One limb of the T wave is greater than the other limb. Also over here it is very prominent, over here it is very prominent. So this is a strain pattern. When you are finding there's a strain pattern in the lateral leads, so you know that the lateral wall is mainly formed by the left ventricle. And another important thing over here is that if you see the R wave height in the V5, it is greater than 30 millimeter, and the S wave height, S wave depth is about 25 millimeter. So whenever you find this 30 of height of R complexes in the V5 and V6, and this depth more than 25, this is a diagnostic of left ventricular hypertrophy. In this last ECG, you can find a P wave in the lead 2, so it's a sinus rhythm. Lead 1 and AVF both are upwards, axis is normal, and then you start looking at the P wave, PR intervals, and the ST segment from the lead 1. Again, in the lead 1 you can see the ST segment elevation. So when it is in the lead 1 is a lateral lead, so it's present in lead 1, lead AVL, lead V5, and lead V6, the ST segment elevation. Along with that, then you start looking at the lead 2. In the lead 2, here you can see that it's normal, and lead 3 is also normal, but you can see a sort of ST segment depression in the lead 3. And you can see small Q waves as well in the lead AVL, and also there is a Q wave in the lead V4. First downward deflection is basically the Q wave. So this is interoseptal myocardial infarction. As you can see, the ST segment elevation in V3 and V4 as well. So interoseptal STEMI. Another important thing that I wanted you people to pick, though it is not that much significant, but an ugly looking QRS complex. This is an extrasystole, and you can see the morphology of the QRS complexes that is very different from rest of the QRS complexes present in the lead. So this is in PVC. So this is end of the ECGs. Hope it helped you.